Next speaker, Dr. SHETTY. Panaah SHETTY, sorry.
Good afternoon to one and all present here. Today I'll be talking on the topic, are all thin corneas indicative of keratoconus? So as we know, thin corneas are considered as challenging cases in refractive surgery, and at least 12% of all our refractive candidates may present with the corneal thickness of less than 475 microns. So what is the literature says? What is the best option available with us? ICL is considered one of the best options, where it corrects the corneal error, it corrects the refractive error in thin corneas as well as corrects a higher refractive error also. But there are certain disadvantages, for which are there any other laser refractive surgeries to help us correct the thin corneas of their refractive power. So literature also states that PRK is considered one of the safest procedures for thin corneas, but there are chances of iatrogenic ectasias that is seen most commonly if there is any preoperatively subclinical keratoconus present. So, but how do we identify this subclinical keratoconus? That has remain a challenge since eons right now. So that is where the knowledge gap persists, because we just see at the topographies and not at the corneal architecture. So we took this study forward, and first we looked at, are all thin corneas considered unhealthy or pathological? So we took 200 eyes were studied with the corneal thickness of 450 to 490 microns, who were highly motivated for refractive surgery and were divided into group 1 and group 2. Group 1 containing of thin corneas with normal topography, whereas group 2 was thin corneas with abnormal topographies. They underwent a clinical evaluation of corneal topography and corneal biomechanics, and the corneal architecture was studied with the help of PSOCT. Now PSOCT is an in vivo imaging device that helps in identifying the collagen orientation and density with the help of corneal birefringence principle. So it gives us the phase retardation, which helps us to assess the corneal thickness. As you can see, there is a reference map and also the patient phase retardation maps, which help us to show that the collagen density and orientation. This is one of the first machines to give even the Bowman's thickness. So now let's look at the methodology once again. So group 1 was normal topography, group 2 abnormal. When we look beneath into the architecture, we can see in group 1 the corneal collagen and orientation with reference to the reference phase retardation was good, whereas it was poor in group 2. Similarly, we also compared the biomechanics, that is SPA1 and CBI, and saw that the same theory was continuing, that is group 1 was stronger, whereas the group 2 was not that strong and was tending towards the subclinical keratoconus. The same thing was shown by our phase retardation by PSOCT. Coming to the AI grading done for keratoconus by our PSOCT, we have seen that in the AI scoring also, group 1 showed lesser incidence of the subclinical keratoconus. So coming to the second question now, is it safe to perform PRK surgery in non-keratoconic eyes that are thin? So our methodology, again we involved 40 eyes who underwent the surgery, and on a 3-year follow-up we saw that all the patients, none of them showed any regression of power. All of them presented with 20/20 vision, and the coefficient of variation was 0.94. There was no ectasia seen in the topography maps. Even in the phase retardation, it was a healthy, good collagen. And even the AI scoring showed that they were healthy. There was no incidence of subclinical or any incidence of keratoconus. So I would like to tell everyone, like a takeaway home message, that PSOCT, you have to look beneath the topography. Topography is not everything. You need to look beneath how is the collagen, how is the architecture. That is what is the defining part of subclinical keratoconus. It's not wrong to do PRK, but you need to identify subclinical keratoconus to stop the incidence of ectasia. Thank you.
Did you correlate anything with the posterior corneal elevation in these patients?
So no. So posterior corneal elevation was kept below 17 microns. So any patient that was considered already keratoconus was not taken into the study.
Okay, thank you.
Thank you.